transmission. What is the genetic transmission here?
Son has the disease and the daughter the carrier.
That's right. So the mother is infected. Right? You have a carrier mother and a dad who's fine. So with each pregnancy, this is true for any of the genetic conditions we're talking about, the risk is with each pregnancy. It's not with the number of children. People think, oh, I have my one child that has whatever, so the other children will be fine. No, this risk is with each pregnancy. Each pregnancy, she has a risk of having a 25% chance of having a normal son, a 25% chance of having a normal daughter, 25% chance of having a second carrier, female, and a 50% chance of having, 25% chance of having a second son.
So the father...
50% of the children will be either carrier or second.
So the father...
Fine.
Can the father be a carrier?
Yeah.
So the father's carrier, mother's carrier, then...
Yeah, the risk changes. Yeah, 50%.
Father is carrying out the father is carrying.
No. Yes. Up to 75%.
But it's not...
So, the thing is, you want to remember, you got deep into genetics here in a minute, but what you need to remember is this X-ray transmission is from mother to son for the disease. The daughter will be a carrier. In very rare instances, you may have an affected father and a carrier mother, so that increases the risk of having a daughter that could be affected. But in all my years of practice, I have not seen a female affected with hemophilia. Nothing happens. We just say that it's very rare. Some hands up over here.
Once the egg has the hemophilia type,
it's not a carrier. He's always affected. Because if he has one egg, and his mom gives him that infected egg, that double egg he has, so he has, females have double egg, so that second egg can bounce off. Say again? Yes, the boys are most often affected. So there are two types of hemophilia. Hemophilia A.
the boys, we have 75% of the
No. He brought up a scenario where mom's affected, dad's affected. And two affected parents. So then the mom has hemophilia, dad, not just carrier, mom has hemophilia, dad has hemophilia. That's what I was talking about. The risk can be that high. Still be a very high risk for mutation. But we can manage a lot of high risk. So then we do other types of bleeding disorders that have babies. They're just high risk and they're managed differently. That's a good question. Yeah. Okay, so hemophilia, there are two types, A and B, right? So hemophilia A, show you what it is, okay? And the other thing you need to remember is which clotting factor is missing in each type of hemophilia. So A is what? So A is missing in hemophilia A, and 9. Factor 9 is missing. Good. Okay. A is A. Yes. The thing with hemophilia, there are degrees of severity. So it's either mild, moderate, or severe. So if I said to you that this child has 1% clotting factor, is that child mildly affected, moderately, or severely affected? 1% of them is severely affected. They have less than 1%. 1% is less clotting factor. In your book, it's a nice little table that gives you the percentages. I want to take a look at that. So other thing I wanted to point out, even though we said it's like genetic transmission, right? But a better case is there is no family history. They're called fresh gene mutations. Something happened, we don't know why it happened, but these kids develop hemophilia. These are some of the cases of hemophilia here. Hemophilia B is also known as Christmas disease. That's the Christmas tree. Has nothing to do with Christmas though. Was this Christmas disease because the child that was first diagnosed with this? Same with Christmas. Christmas disease. And then for 20%, and then the child is missing factor 9. So what are the manifestations? Bleeding. Now, depending on how much factor you have missing, you can have continuous bleeding. I didn't injure myself, I coughed, and I coughed up there. Because I have that much factor missing. And if you deal with celiac, they can have continuous bleeding. And just think about it, they can have continuous bleeding anywhere in their body. So I can have a continuous bleed in my brain. What is that called? In the brain? Yeah, so I can bleed into my lungs. I can bleed into my abdomen. For no reason at all except I don't have time factor. And maybe I been just in a deep cough or a nice deep breath and rubbed some of those tiny micro vessels like me. That's what you get in the field. So tendencies can bleed to be mild to severe, just like hemophilia itself can be mild to severe. So if I have mild hemophilia, my bleeding tendency will be much lower than someone who has severe hemophilia. Make sense? Okay. We don't see symptoms in kids until after age 6 months. Like age 6 months. Why is that? They're born with it. Right. They're getting more, they're getting more mobile so they can bang, you know, and then we see bruises like, oh my God, this kid's bruising for no reason. We worry most about hemorrhagitis, which is bleeding into the joints, into the large joints of the hip, the knees, elbows, ankles. It's because the risk of joint deformity is high. We want to control that bleeding and we want to begin to rehabilitate that joint as soon as we can. Okay? So hemorrhagitis. So if I'm bleeding from my joint, what would you see? Dryness. Pain, and they turn purple depending on how long I've been bleeding, right? I feel like I'm bleeding there. It's having warm, depending on how long, and have a mobility issue. I don't want to move it because it hurts. I got extra fluid in my joints, you know, and it's painful. I was actually thinking about this lecture this weekend. I think I told you that. I tell about my medical history. I don't care. Forget HIPAA. I'm telling you. That I had 2 episodes of pulmonary emboli over the last 2 years now. And so I take warfarin. You know what warfarin is, right? So I woke up on Saturday with this knee pain. My knee hurt. It felt kind of cushy and soft. And I do feel monitoring for my iron out. I pulled out my low machine and I checked my iron out and it was 3.3. Is that okay?
No.
My goal is 2 to 3. So being the nurse I am, I didn't take my Coumadin. I emailed my doctor and I said, I want this high testing. And I was 3.3. I didn't take my Coumadin, blah, blah, blah. Didn't hear anything back. The nurse called me Monday morning and she laid me out. You are not a doctor. You should not be touching your medicine. You need to get that medicine. Blah, 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 blah. And I said to her, well, I felt it was okay. 0.3 is high. I've never been there. I stayed 2.1 to 2.5. So even going above 2.5 for me was high. And then she sent me back an email. She said, I'm sorry I was so rough with you this morning. I couldn't ever told you were the same subject. I'm sorry that you really reared me up for no reason, but so my thought was, what happened to my process? And what I was thinking, am I bleeding into my joint? I don't have hemophilia, but I take a blood test. Am I bleeding into my joint? So, it's better now. Another thing is ecchymosis. Something else we talked about. Ecchymosis is a symptom we look for and we include in our assessment, and we ask more questions when we see it. Because it's what? What is ecchymosis? Child abuse. It's bruising. So a child with hemophilia can be misdiagnosed as being abused because they bruise a lot. Bruise very, very easily, and they can have really deep bruise too. So other things will be nosebleed, sepsis, and then the bleed after minor procedure. So you should start thinking right now, if my kid needs surgery, we need to put them in a very well-controlled environment, right? Oral surgery, you're not going to do it in the office. You do it in the operating room. Because this child's airway needs to be protected, and you need to be able to put those fluids in supplementation if they start bleeding, and transfuse them, and give factors. So you need to be in an area where you can do that. The other big thing is wherever anything that's in the chest or the neck area. If I'm breathing into my throat, I don't want to compromise my airway. So anytime there's bleeding in this area, if I'm breathing in my chest cavity, I'm going to compress my lungs. That can have to be interesting. So anything that compromises the airway, we want to pay really close attention to. Second question. Apply ice for 15 to 30 minutes continuously, and then elevate the extremity. 36% you said yes to that. Why? What's your rationale?
You want to stop the bleeding? It's going to constrict the blood vessels.
That's true. Ice will constrict blood vessels.
I would never do ibuprofen because the child is bleeding already.
No, not really. That's kind of the normal range, right? Yeah, if you have a trauma injury, yeah. So, what else you want? I disagree with you on A, so.
Okay.
I disagree with you on A. So tell me why. Why do I disagree with you?
I don't know what you're asking.
Right. Yeah. Here's the deal, guys. If you have a normal patient, and this is where it makes it hard for you to think on your test, you have so much information about patients here right now. A lot of things that you've learned and you put up here and you just kind of apply it. Stop and think about who's my patient. Not every intervention is going to be correct for every patient with that same diagnosis, right? In this case, we want to know who our patient is. Our patient has hemophilia. This is not just a normal kid who fell and bumped his elbow. So yeah, so I put my elbow on the normal starting, you put ice on it, it's gonna vasoconstrict, and I'm gonna stop bleeding. When I have little and no clotting factor, which really moderate is significant enough that I have significant factor loss, that I'm gonna bleed, regardless of what you do with that ice. And I'm saying that. The patient bleeding right, the ice pack was on the child's arm, in his school, he fractured his arm, because of the splint, the nurse did this nitro rag, a computer fracture, communicative fracture, I don't know if you can see the bone sticking out, bleeding everywhere. They stabilized that arm really well, put a huge ice pack on it, and sent it to the hospital. And this kid bled through everything. The paramedic says, he's bleeding, we've been putting ice, we've been putting pressure, he's bleeding, why is he bleeding, why is he bleeding? And the pediatrician looked at the parents and said, "Anybody in your family has any problem with bleeding?" He said, "No." He said, "Well, we need to do a test. So we're going to fix this, try to stabilize his arm, but we need to do that test right now." The kid had hemophilia. I don't know to what degree, but he had hemophilia A. So he got factor replacement, and then went to surgery to have his arm fixed. So the message there is ice is going to slow down bleeding for your normal patients. Patients with hemophilia don't have body factors, so no matter how much ice you put on, to freeze their arm off, they're still bleeding. So there's nothing to stop it. There's nothing to stop the bleeding. Okay? I don't know what happened to G and D. That's elevate. That's the element that finishes compress the injured elbow with the physio and administer ibuprofen. No, what's ibuprofen? Alright, so you know why those two depend. Alright, guys, good job. Alright, so let's look at, here we can freak out. You can diagnose this in utero. And you think you just said we can talk to freedom of asking parents if anybody had a bleeding disorder, so you look at the family history, you do genetic testing, but you remember that you also have a third of the affected people who would have no genetic explanation for their disease. But here's the both sides. It's right here. Okay. If I have a prolonged PCT, what does that mean? What clot? No. Yeah, I won't clot like the normal person because it's prolonged. Okay? So you want to pay attention to that on your lab report. And that may be the key. You might be the key to them diagnosing this kid or this adult, whoever it is. But you look at the lab and you go, that's a prolonged PCT. Hey, guys, take a look. I'm going to check out this kid a little bit closer. So for medical management, and I want you to write the word mild in that box after DGA is repeated. I'm going to use for mild to repeat. Anybody find the box in that book that has the percentage of within factor?
The old book is of what you're supposed to do.
Okay, okay. 1358. Okay, can you read that one back? I don't have glasses.
Clinical severity.
Alright, guys, listen.
Severe is less than 1% of factor 8 activity. Bleeding tendency, spontaneous bleeding without trauma. Moderate is 1% to 5% factor 8 activity. Bleeding with trauma. Mild is greater than 5% to 40%. Bleeding with severe trauma or hurt.
What did you notice about information in that box? Maybe for something. Anything confusing? Is it for both hemophilia types? So it's hemophilia C, right? Oh, yeah, A. I'm sorry. Get my wires crossed. Hemophilia A, factor 8. Okay? Hemophilia B is like 20% of the time people have it, so we don't have the grading for it. However, hematologists will tell you they use the same rate. But for test purposes on your test, I'm going to ask you. ask you what's in it. Okay? So hemophilia A, you have mild, moderate, and severe. And I just told you, DDAVP can be used to treat mild. And what it does, it boosts the factor development 3 or 4 times the rate. It's given IV, and it just says right there, used for mild hemophilia. Okay. So our medical management, if we have mild hemophilia, would be to give the child DDAVP, replace the missing clotting factor, and transfuse or infuse fluid and blood, depending on how symptomatic they are. At home, if this child is at home, if this child is at school, wherever this child is, everybody in this child circle needs to know A, this is their diagnosis, B, this is their emergency management plan. Okay? Parents are actually taught to start IVs and to access ports. Young children, toddlers and infants will have an issue with ports because they can't pull. Okay? Older kids, parents can start intermittent IVs, increase the factor, reduce the IV. Okay? So they can have their home therapy done. They keep the factor at home, and then all of the supplies and parents can do it. Prognosis. Used to be that we say by age 5, children with moderate to severe hemophilia didn't live past age 5. That's no longer true. Now, mild to moderate hemophilia patients can live normal life. I have a story I always tell when I teach this. My daughter went to college in New York. And one night I was sitting at home, and she called me, I'm not to be able to train very, very well. You're not buddy. What is that you doing all this thing? I didn't ask you a good question. I said, what? What is hemophilia? I said, why are you asking? I was just asking the question. So I explained to her hemophilia. That's what he asked. I said, who? My friend. And we got off the train just now. Mom, I think about it's been less than 10 minutes. And his knee is almost twice the size. He bumped his knee. I don't know if you've been in the New York subway, but they have those columns. And he got out of the train and bumped his knee on the column. And his knee was swelling, and so she's freaking out because she knew he was a hemophiliac, but she didn't know what it was. So I said, she said, so what do we do? I said, you need to go to the emergency room, call the EMTs, go back to the dorm, because I'm sure he has his clotting factor. If he's been a hemophiliac and he's in college, he's been a hemophiliac since he was born. And somewhere he was diagnosed. Unless it's something, if you know he's a hemophiliac, he's been diagnosed. Okay? So I said, let me talk to him. He comes on the phone and tells me he's 20. My daughter was 19 at the time. He's 20 and they were going to a concert. And he said, yeah, I think it's just a little bleed, but I have my clotting factor at home. I'll take it when I come back from the concert. You know what? I think I'm just going to go up to the pharmacy here and get me an age wrap. I can wrap it up and then, when we get back from the concert, you take it for real expensive. Just what you give me. He said, give me other reasons why he won't go back. And I said, okay, let me tell you something. You need to turn around, go home, and take your clotting factor. He got a little quiet. I said, let me talk to my daughter. And I said, he's going to die. She said, Mom, you lied to me. I said, no, I didn't. I have to get very, very, very dramatic to get you guys to do what you needed to do. But can you see the developmental issue there? Yeah. 19 and 20-year-old people feel insane. Yeah. I can wait. I'm going to talk about jumping under the concept, doing some more. People are like, yeah. I wish I didn't made it. Well, the thing, my cousin actually was telling you that there are people living with hemophilia now who 20 years ago, he was moderate hemophilia did. Severe hemophilia, on the other hand, has such complicated bleeding, major bleeding, that even with survival, we're seeing very, very severe complications. Like they may have had many, many strokes. So think of all of the deficits of stroke. You can have a GI bleed. You they have respiratory issues. So most cases still, life expectancy is still kind of possible. But it's still longer than what it used to be. The hope is with gene therapy. But the number of listeners to go to, so we can turn that gene off. Fix it, so we start with the chronic factors, and we can feel this thing. Alright, so here are interventions. You can look at them. We talked about them kind of going through the questions. I just want to point out two things here. One is that this whole business of shaving was new, very, very new to me, and I don't know about everybody in the class. I never heard of a woman shaving their legs or back into this country. Never did it. Didn't know how. And my daughter was head of her cheerleading squad, and yay. I got this call from her coach, and she goes, "Your mother doesn't take care of her hygiene." She does bathing and all the pillows. And I was like, "Yes, she does." She said, "Well, her legs are too hairy." So what am I supposed to do about that? She needs to shave them. Oh, how do you do that? This way you have to teach me how to shave legs so I can teach my child, but you can share the cheerleading squad. But anyway, the answer here is, we got nipped a lot of times with that, with razors, because she knew what she was doing. I didn't know what she was doing anyway. So you really want to encourage electric razors for people with any kind of bleeding disorder. Yes? But especially when you see that. So you have to think about the young men as they begin to shave. Shave their hair. You know, you have to wear hair, men and women. So anyway, that was a nice one. Talk about culture shock, huh? My leg. I still have my leg. I said, "Look, Mom doesn't have any hair." She never had. So you have a home replacement therapy. The child is Celsius. The child can begin home replacement therapy as young as 8 to 10 years of age. So I'm a hemophilia. I'm being taught how to do my home infusion at that age. So I knew this when I'm dealing with a 20-year-old. He has 12 years of practice. So, but the thing is that you can either do it, some kids are almost called regular. So every day you get a replacement factor, especially for your severe hemophilia, or you do it prophylactically. If I know you're going to have a dental treatment, or we're going in for immunization, anything that I know is going to break this can will give you the factor. So that's managing hematosis, you got that from there. Replace the factor and then do the rest of the range of motion exercises. What type should this patient do? When? Active and when? Think about what's going on in the joint. Maybe you want to make sure first before you want to do active range of motion. You're right, it should be active because active they're doing it. Right? Active I'm doing it. But the bleeding stops. You want to make sure they're not bleeding anymore, because you know what? When I do this, if there's a clot trying to form, I'll break it. Right? So I want to make sure they're not bleeding anymore, and I'm doing that so I can preserve joint function. Here's the case study. This is not a trick question, so you need to read it. Listen. 2-year-old with hemophilia is being discharged. The nurse is completing the discharge teaching with the parents. Which of the following statements by the parents indicate they require further teaching regarding hemophilia? And this is a multiple answer question.
So it's a multiple answer one?
Yes. See, like all that slide. Are you alright? Here's your option. Yeah. They need further teaching, right? Yeah, they need further teaching. Which one is that? You don't want to get aspirin and they will not get aspirin. They will not get aspirin. Okay, it's good to know that my sister will not get hemophilia. Do we know that? No. Okay, don't know that. So we need to clarify that word that we don't know. We don't know what genetic trait they have. B, son, if our son has a temperature, we will not give aspirin or ibuprofen. That's right. C, that's right. D,
But you kind of going to
sure. It's a sure. But if you said okay, leaders, we will be sure to watch our son very closely to make sure he doesn't have another episode of bleeding. No, that ain't possible. I don't watch Erica. I'm not going to bleed. You're not going to bleed. Watching anything. I can't even do that. So, Andy, are your answers?
So now I thought Tylenol. So Tylenol doesn't interfere with bleeding?
No.
Or with clotting and stuff?
No, I just hope that. This is a review slide. We're going to talk about the anemia now. So you can look at that at your leisure. Red cells, this is what it should look like when they're normal. You know what sickle cell anemia trait? Anybody here never met anyone with sickle cell disease trait? Hello, you just met one, Jessica. I am. Sickle cell trait is actually a protective trait. Sickle cell trait is protective against malaria. So people from West African countries tend to have a high rate of sickle cell trait. And the key is don't marry someone with sickle cell trait. And you'll be fine. But have the disease, you know? So what does that mean? Understand if you don't marry someone with sickle cell trait, your offspring won't have the disease. What does that mean? It is autosomal recessive. So you will both parents be carriers of the gene that will affect your child. So this is what the sickle cell looks like. A lot of times, I want you to think about it this way, because I think sometimes you understand the foundation is pushing through. The cells are not always sickle. Patients have the tendency to sickle because they have the genetic makeup. Alright? Under the right conditions, they will sickle. But they're not always sickle. That's why people with sickle cell can have extended period of well-being, and then they have a crisis, and then they have extended period of well-being, because the cells are not always sickle. Second point, sickle cells are all chip cells. That's all they are. People think they look like an ass. They don't. Look at these cells, and look at this, remember the slide I showed you before with the normal red blood cells? These are all red blood cells, okay, but they're different shapes. How long does the red blood cell live? 120 years. When the red blood cells get sickle, it becomes very fragile. So it doesn't live 120 days. It also becomes very sticky. So they tend to swing together. So the patient, when they have sickle cell crisis, they have cells that have chain shape that have become sticky, and they're clumping together, and they're blocking the passageway for nutrients for the cell. Underlying physiology and what's happening in sickle cell disease. All right? So I show you a slide that shows you normal cells and some sickle cells within what your patient might look like. Depending on the degree of sickling, then they become symptomatic. What makes them sickle? Now, these are the big four. These are the big four. Oxygen tension, causes the cell to stay still, or decrease tension. Yeah, what makes the cells change? Because they have the genetic disposition to do it, but they don't do it all the time. Under certain conditions, they sickle, and these are the conditions here. Go ahead,
That's why I was thinking about this football player who plays
go to Colorado. That's a NFL player. I think he plays for Boston. The England Patriots, I think. But whenever the team goes to Denver to play, he doesn't go because he has sickle cell disease and it causes him to have crisis. And the reason is because Denver treated with call mile high. It is a mile high. Yeah. Yeah. I went there many times. I actually didn't know this. My car stalled. And I was like, what? Yeah, so that's it. This is orchid center. Remember all the people who fly long flights? That's why even though the cabin is pressurized, to keep you comfortable, breathe easy, then you still have some risk. So mountain climbing is not just sport for me, because I have sickle cell, okay? Academia. What are some conditions you learn that you say, oh, I think they would have problems to have this. Diarrhea, right? So GI infection. Okay? And then that goes along with your increased plasma osmolality also.
Diarrhea?
Yeah, diarrhea. So dehydration. And if the environmental temperature is too low, so like wintertime, they can don't get confused because they can also sickle because with diarrhea and dehydration, you can have temperature elevation, right? Internal temperature, you can have a fever. So fever can make them sickle. But what this is talking about when it says low temp is the environmental temperature. Cooler environment.
Because that will cause your body to produce more heat?
Yeah, you raise your metabolic rate, yes.
And then that
And
would
you heat the body, yes.
you would use more oxygen, you would increase your CO2.
And you make fluid pollution, kind of make everything go south. Vaso-occlusive crisis or episode, big deal. Fly, sickle cell patients end up in the hospital. Okay? The word itself is telling you what's happening. Vaso-occlusive. These cells have clumped together. They block the passageway for blood and nutrients to the cell. So the tissue beneath that blockage, craving for those things, sending a signal to the brain and saying, hey, I need food, I need water, I need help down here. And the patient has to be okay. Severe pain, it can be self-limiting, but it also can lead to major complications like chest syndrome. So here's a big mistake that nurses, and this is mostly experienced nurses, because one thing I always tell people, I love working with new graduate nurses. Not only because I was a nursing instructor, but because new graduates keep you on your toes. They ask you questions like, why are you doing that? Nursing school, and you say, oh my God, I never go down nursing school. But for me, that was my cue to stop. Oh, it's not making sense to them. So I need to stop explaining it. Maybe when I explain it, it makes sense to me. And I say, oh no, that's not making sense either to me. So I need to go talk to the doctor about this. So when you think about chest syndrome, it's a perfect example where patients with sickle cell has pain crisis, right? There's a patient that shows up with some pain, screaming with abdominal pain, pain in their joints, wherever, and all of a sudden they begin to complain of chest pain. You know that chest pain is never benign. You know that, right? Whenever I have chest pain, if you are prioritizing symptoms, that's where you're going to go first, right? You want to figure out why that chest pain is there. So just because this patient has a history of having chronic pain shouldn't cloud your assessment. This is new. The sudden onset of chest pain in your patient is a complication of sickle cell. What's happening is this patient is having ischemia of their lungs. If you don't do anything about it, they'll die. So if they complain about chest pain, you need to take it as a medical emergency and respond appropriately. Right? Otherwise, you know they have acute pain, and we need to figure out what we're going to do about the pain. And you like to treat pain. You want the patient to be comfortable, right? Here's a system. A 14-year-old boy with sickle cell. He has severe pain in his abdomen and legs. He asked why the doctor ordered oxygen when he is not having problems breathing. The nurse would reply that the main therapeutic benefit of oxygen is for this patient. Oxygen for this patient. What is the therapeutic benefit of giving this patient oxygen? Because he's saying, I don't have trouble breathing. I want to know why you're giving me oxygen. Here you have it. Why are you giving him oxygen? Not a simple question, James. I heard A, I heard B. How many I heard? So let's do A first. What's the rationale for A? Yeah. You remember what I said? It's simple because they have low oxygen. Okay? So if you give them oxygen, you're going to prevent further sickness. Okay? How about C?
Well, the red blood cells only carry so much.
Bingo. So my normal red blood cells can carry X amount of oxygen, right? When my red blood cells are sick, remember me telling you that they change shape, they get sickly, they lose some of their surface and their oxygen carrying capacity. So I can give you all the oxygen I want. They can't carry it anywhere. So it's not to increase their carrying capacity. I need to stop the sickling in order to do that. Make sense?
Yeah, that's just right
You
now.
say, wow.
But the respiratory complications, I think, is called sickling, so you can get the sickling down.
If you can prevent sickling, you can prevent the respiratory complications. Because some sickling is why the ischemia to the lungs. The spotting that's happening in the mitral vessels. So you can stop the sickling, you can take care of the rest of that. So yes, the O2 and 4 is to stop the sickling. Now, we're going to go back to that question because I want to give you another scenario. That's not on here. Same patient, a 14-year-old severe abdominal pain. This time, he has several orders. And I want you to prioritize them. Ready? Administer morphine every 3 hours. Start IV fluid. One and a half times maintenance. Start IV fluid 1.5 times maintenance. But I tell you morphine, I could do it administer oxygen by nasal cannula to maintain fat above 94. And teach the parents and the child about clinic sequestration. So I want you to prioritize those 4. Which one will you do first? About what? The first one I said was morphine. The second one is fluid. The third one is oxygen. And the fourth one is teaching. Based on the complication. So what are you going to do first? Oxygen. So that's rethinking that. Okay. So he's not in any respiratory distress. So why are you giving him oxygen? Okay. I want you guys to think about the physiology of sickle cell. What's happening at the tissue level? Because that's what's going to help you figure it out. So you have occlusion of the vessel. You have tissue down here that's kind of cramping up because they want some fluids, some nutrients. How am I going to stop this? Because this is what causes my pain. Tissue is dehydrated fluid, then more pain. Oxygen coming into. So let's talk about that. If I have no ability to get anything past this occlusion, no amount of pain meds you give me will solve my problem. I may be comfortable for the 3 hours that you give me in the morphine, and right after those 3 hours, I'm back where I was, or maybe even more. The pain has even gotten worse because my tissue hypoxia is still there. Because I don't have anything to get the medication and the oxygen that you give me to the tissue. Because I have a blockage here. When you hydrate the patient, you open up the passageway. Whatever you give them after that gets to the tissue, and it takes care of their pain, you take care of their hydration, you decrease the sickling, all by doing that. Make sense? Yes, so you want to take care of, this is one time when I teach that the airway is not always, and A is not always airway. One time. Okay? Because your patient's fine, he told you, that's the one that's really okay. Why are you giving me oxygen? Well, the first answer was you didn't stick with, okay? This time around, you really want to get that tissue hypoxia and perfusion issue resolved. Okay? Alright, so if you look at this, you see that we talked about hydration, we talked about tissue perfusion, you want to promote that, and you want to use the analgesic around the clock. One of the things that we need to stress, and we talked about this, and we talked about pain, is that PRN meds don't work. They don't, you hear nurses say things like, oh, that's a clock watcher. He calls me every 3 hours because I told him that medicine of her is due every 3 hours. So why is the patient doing that? To be the answer. And this is what a new grad attitude comes in. Nurse sitting in there complaining, wait a minute. So why is the patient doing that? What's wrong? Morphine is supposed to be a good drug, so why is she not getting any relief from it? That's the beginning of the critical thinking. Because here's something that you probably may not have known. There was a big study done several years ago in this area, DC, Virginia, and Delaware, or the three, DC, Maryland, Virginia, and Delaware, still states. It was a pain consortium. And they did a study of young men between 18 to 24 who had sickle cell disease, where I had multiple hospital admissions. What they found in that study was that morphine did not work as well in that population. So there was a follow-up to why. I think that didn't work. A lot of the patients that they were in that study either had problems with dependency or addiction to the pain medication. And what they found was when they actually looked at the chemical makeup of the blood and this enzyme that's needed to metabolize morphine, in that population it was very, very low. So morphine was not the drug of choice for this. Morphine actually contributed to their drug problem. And when you look back at the medical records, you see they were in the hospital because nobody was managing their pain. So your job as nurses is to look at that patient and say, well, wait a minute, there are other drugs out here. Yeah, morphine will work for everybody else. Who is good at enough study that said morphine is the gold standard? Was it really a very mixed population? Does it really work for everyone? Rather than assuming this patient is drug seeking, talk watching, we don't believe. We need to be good nurses and say, wait a minute, let me look at my patients for who they are and go to the doctor and say, hey, God, is this something I put in time here? This is really not working for this kid. I'm giving him the morphine and 2 hours later he's crying, he's whining, he's not getting comfortable, and I just think it's not working. Okay? So think about it around the clock and the fact that we do good assessments around pain medication.
So is morphine working with just morphine that open, or was it?
It was morphine that we studied.
Okay.
We didn't study anything else. So we don't know. But at least they have the knowledge to know that if the patient is on the Dilaudid or something else, and they have the same reaction, then we need to look at the something else. Yeah. Second question. Okay. At birth, the full-term newborn has maternal source of iron. The last trimester is where babies store up everything they need. You know, it's kind of like little parasites. Take. I'm getting it out of here. I didn't take everything I can with me. So they store up iron, they store up brown fat, maternal antibodies. So when you're thinking of a full-term baby, that's true. Preterm babies didn't have enough time to do that. So they may not fit this category. Okay? Whatever they have in terms of iron stores lasts about 6 months. So the right answer is 8. 5 to 6 months. And if you didn't know this, here's another little trick. You didn't know this. They hadn't learned it yet. You look at it and you say, you know, I have learned something about insurance. What do we introduce college? And why are we doing it around there? Because you know that maternal stores are going down. Now, if mom's breastfeeding, you might not get to 6 months. You want to start iron at age 2 months. Solely breastfeeding. Breast milk is very low in iron. So you need the supplement. Even though they may have stored up, they're not stored after. They break down pretty quickly. Alright? But for this question, it didn't tell you whether it was breastfeeding or bottle feeding or whatever, 6 months is where we begin. So iron deficiency anemia in the pediatric population, you can think of an infant being anemic. You can have a school-age child that's anemic, preschooler, adolescent. Okay? And they may all be related to nutrition, or it could be related to loss of blood loss, or it could be related to their metabolic rate, okay? Or poor absorption. But in this case, we're talking about iron deficiency as a nutritional deficit. So what is iron? What is iron? Remember that table? Periodic table, yes, you got food on that table. Yeah. I don't know, but it's an element. So it's important that you know that elements do something. They like to bind the things, to move. So think about iron in that capacity. If I were to ask you, when is the best time to to give your patient an iron treat tablet or elixir, they're getting oral iron in relation to their meal. When is the best time to give it? Before meals. In between meals, before meals. Why are you saying that? Well, better because yes, that is a gastric acid. So iron is absorbed best in an acidic environment. But what are the side effects of iron? Constipation, heart rate. How about the GI? Irritant. So when you say give it an empty stomach, give it with something citrus, yes. For your adult patients or your older adolescent might get a vitamin C with it, or they might take it with orange juice. Or they have the vitamin C that comes with it, right? Like with the iron in it. So you know that it's absorbed that way. So these kids, these babies tend to be chubby. They're really fat babies. We sometimes call them milk babies because their diet has been really high in cow's milk, and they have very little hemoglobin, so they're pretty pale, but they're fat, chubby, beautiful babies. The reason you'll know all is not well because you kind of equate a fat baby to a healthy baby. Like, you know, it's, oh, that's a very healthy baby. If I'm 8 months old and you put me in a room with a lot of toys around, what do you expect me to do? Try to go to it, right? But if I sit there and look at the toy, and look at the toy, and look at you, and look at the toy, and finally I go, I'm tired to come to you. You see that? So one of the classic symptoms of anemia is what? The infant can have fatigue too, right? How do you know it? They can't tell you I'm tired. I just showed you. They're not doing what you expect them to do. They're fat babies. You look at their diet, you can see that all they've been drinking is milk, and they try to drink 4 or 5 8-ounce bottles of milk a day, and followed by 4 or 5 bottles of juice a day, and they're fat. Parents just know they're fat. So we really need to fix this. It's a dietary fix. Supplement the iron and fix their diet. That's all you need to do with it. For your oldest child, you have other things. Adolescent girl, what is her risk? Yeah, she's losing blood. And what else? What's her other risk? Her diet. Yeah. Well, I wasn't sad. Like you want me to know, I wasn't sad. I heard that many years. But anyway, I wasn't sad. I was daughter who said, I eat no vegetables, Mom. That's nasty. So go to McDonald's, take the sausage, take the burger and the bun, and take everything else out of it. I still want to be fat. To believe that made her fat. You need to eat in the bun. Yeah, right. But teenagers get into these things, right? They prefer to go to McDonald's, any fast food place, get a burger and a milkshake. Take out all of the lettuce, the tomatoes, the onions, eat that, drink a milkshake, and they're full. Okay? So green leafy vegetables are the best way to get your oral iron in through your diet when you're older, right? And so these kids tend to be anemic because of that. They're losing, plus you have a high metabolic rate. So your teenager and your infant tend to be the big two groups that are at most risk for this. Not that other kids can't have it, but these are the guys because of where they are. So when we're giving oral iron, what do we want to tell the parents? Rinse out the mouth of their infant, give them something to drink after it, brush their teeth afterwards. We're going to talk about constipation. Yes, we're going to talk about constipation. Do we give children laxatives? So what are we going to tell the parents? Fluid and fiber. Okay, so fruits are good. And we want them to look for that green forest food. Even though you say side effect, it's actually how we know the thing's working. Okay? People who are anemic have stool that has no color. You guys know that? You know, stool has a color to it, right? So you see white stool, you need to stop and think. I just see white. So you need that. And the last thing you want to remember, iron can be toxic. So like any medication that they have at home, they need to store it so the child doesn't get into it on time. Any questions on iron? Iron can be given again, oral and what? Oral.
What do you can do it?
Now someone told me that, I don't know if your class or not, that you no longer learn D-track. And then what's the rationale for that? Help me understand it. It was more. Everything says practice, I tell you, I need to look that up. But the only drug that I've ever given D-track was injectable iron. And the reason is because it's toxic to the tissue. So you want to make sure that it's deep in the muscle and nothing else is trapped. So you kind of D-track so you take it off. Yeah, but I know it's still in your book, but I knew in lab someone had said that they weren't teaching that anymore, but this is a technical thing that's still saying that.
And we got one of my associates here article about that last time.
Okay. Yeah, that's the new evidence, but again, your book, by the time it's published, is 5 years old. So. Anyway. Anything else on the sickle cell anemia, iron deficiency anemia? Yes, breast milk is low in iron. Yeah, so we need to supplement them beginning at age 2 months to get iron drops.
What is the rationale between the cow milk and it's highly taking more cow milk?
Oh, it's the fat. It's two things. Infants do not have whole cow milk. It's not infant formula. But after infancy, it's the fat, the amount of fat in the milk that makes them really chubby, and the fact that the milk itself is chelated agent. So that's a good question. So even if I'm giving the child iron, and they take it, it binds, binds to the iron, and the iron is excreted. The other thing that I forgot to tell you about iron has to do with something that's nutritional but also cultural. There are many cultures where people drink a lot of tea, and there is something in the tea called tannin, that's enzyme, and it actually binds to the iron, and the iron is excreted. So if you have a patient who's taking iron because they're anemic, and they come in and you say, well, you're taking your iron? They say, yeah. You go, no, I don't think so. These labs are telling me it's different. Now, how much should be, and are you taking it, and what are you taking it with? Because they may be taking it and losing it, so it's not making any difference. For instance, yes. But it doesn't mean that you don't supplement with iron. You supplement with iron because breast milk is low in iron. Okay, guys, let's look at febrile seizures and wrap it up. I'm going to try to get away from that. If you can stay a few minutes, that'd be great. If you can right up for it. I'm sorry, but I'm going to stay a few minutes. So in that low scenario you had a low infant that was diagnosed with fever of unknown origin, had a history of having a seizure at home. And the whole idea there was intended to get you to think about febrile seizures. So you can find it, you can find it later. But, so, what are febrile seizures? That's again.
It's usually that happens at the house temperature rises.
Not at the peak. It's not the peak that we're worried about. That child temperature is going up. That's when they're going to see. Boys tend to be more prone to febrile seizures than girls. So in the case study, the parents ask, does my child have epilepsy? Okay?
Yeah. You can't say that the child has.
Yeah. Well, one seizure doesn't define epilepsy. Okay? One more. All right. So will this happen again? It could happen again as long as the baby has movement. So what do we do to prevent it?
Something on there says don't happen, but one thing says you could do them a cooling bath. Don't
Yes, you can. You can do a cooling
not
bath,
ice.
but don't ice bath. Now I have to tell you something about children and fluid and ice. There was I guess I remember being new, but I just thought it was exciting. There was a 14-year-old girl who was in a car accident with her mom. The car slipped into the remains, was there for 14 hours and survived, and they were all saying, well, you have to know, infants and toddlers have this tendency, we call it a shutdown reflex. They can shut down everything but their core organs. So when they're submerged in water, when they can swim, before they learn to walk, they can swim. Have to teach them. Put them in the water and they'll swim. Hold their breath and they'll swim. They can drown unless they're sick. But that little girl in that car, she's amazing everybody because they're like, no baby did that. Yeah, baby. And she was in there for 14 hours. Mom died in the accident. With that. So anyway, when you think about seizure disorder, you want to remember that, number one, what is seizure disorder? Number two, the big deal is, how do you manage your seizure? What do you do for a patient that seizures? And you got all of that in your other classes, so I don't need to teach that. My sometimes that you know that. I do want to ask you, do you know anything about baclofen and intrathecal baclofen? Ever heard of that? Yes, baclofen, what classification of drug is it? It's a muscle relaxer. Baclofen, B-A-C-L-O-P-H-E-N. And it can be given orally and intrathecal route. So what is the intrathecal route? It goes into the spine, So we said it's for cerebral palsy, that's exactly right. Patients use this to relax their muscles. The intrathecal baclofen is housed in a pump that's actually embedded in the lower abdomen, so you won't see it. You let the patient start, or you give an assessment, you might see a scar, and if they're thin, you might see the outline of the pump beneath their skin. The pump is in the lower abdomen, the catheter is threaded from the lower abdomen into the intrathecal space. The patient gets the regular dose of baclofen based on the doctor's order. So the doctor programs that pump and says administer 100 milligrams a day. Okay? So every hour the patient gets a set amount of baclofen and feeds into their bloodstream.
That's a routine.
That is a routine management for patients with cerebral palsy. Patients that have severe muscle rigidity.
How do they do the refills? None of this has important to you to have to go and get it refilled.
Yeah, they put them on the skin and they refill it. And they can change the order. That's what needs to be done. The doctor takes the shoulder like a little wand, moves it around the belly, finds the pump. Once it finds the pump, it's percutaneous. It reads the status of the pump. How much is in it, what's the rate, what's the dose, and right there on that computer screen, the doctor can change the dose. Brings out a piece of information, you're still doing hard copy chart. Right now, it goes directly to the patient electronic medical record. So users need to check their orders. Because you may be down the hall in 25 and the doctor goes in 1, and he changed that back within setting, and you didn't know what are some things you want to be sure of, and you assess as a nurse caring for a patient who's receiving a muscle relaxant. That's the story.
Probably looking at heart.
Because the heart is a muscle, right? Can I over-relax the heart? Sure I can. Yeah. So I need to check this patient, I need to make sure my pulse is fine, my respiratory is fine, my level of oxygen is fine, because that's what it was changed, okay? I do have a nice little video, and I don't know if you guys have gotten into the neuro folder yet to look at these videos, but they're there for you to look at. The other thing that you're going to have after class is my narrative PowerPoint for both neuro and hematology. I posted the ones for respiratory and for another test, and I think 10% of the class looked at it. So I'm telling you, if you didn't get it in class and you feel confused about this, you might find it helpful to go back and review that section. I have your test. I'll review it and lab with you when I see you the rest of this week. That was your